औज़ुबिल्लाहिमिनश्शैतानिर्रजीम बिस्मिल्लाहिर्रहमानिर्रहीम। आज आपके साथ एक नए टॉपिक के साथ टॉपिक शुरू करने से पहले रिमेंबर देयर इज़ नो शॉर्टकट टू सक्सेस, यू हैव टू वर्क हार्ड फॉर इट। सो टुडे वी आर गोइंग फॉर द शॉर्ट केस ऑफ short stature. So the command can be: this is a girl whose parents are concerned about her height. Do GP and relevant. So after the introduction and consent, you do the hand sanitization and exposure, which should ideally be in a single shot, but you have to take care of the modesty of the patient. Then you have to follow the sequence in the form of observation, measurements, and maneuvers. Followed by you have to stand at the foot end and see if the child is sick or well looking. Is there any cyanosis or respiratory distress at rest? Is there any pallor or jaundice? Nutritional status, diagnostic or dysmorphic features. So like in case of the Turner syndrome, which are usually short, the following are the dysmorphic features like low posterior hairline, webbing of the neck, broad chest with widely spaced nipples. So these are some of the dysmorphic features. After that, observations, you have to go for the measurements. Measure the height, measure the arm span, upper segment, then calculate the upper segment to lower segment ratio, weight and FOC. So this is how you can calculate the upper segment, how you calculate the arm span. Okay, so this is copied. So you have to follow these steps to measure the upper segment. Then you calculate the lower segment by subtracting the upper segment from the total height. This is example of the webbed neck and the low set posterior hairline. But since you're looking, this is not a girl, so this cannot be Turner syndrome. It's a case of Noonan syndrome. So after the measurements, the next step is maneuvers. So first you have to do from the front, you have to see patient webbed neck, then you have to see widely spaced nipples and sheet-like chest in case of Turner syndrome, arms and feet together, asymmetry in Russell-Silver syndrome, shoulder together, this is in cleidocranial dysostosis, arms out straight with palms up, cubital valgus, normal angle is 15 degrees in the girls and 10 degrees in boys. Simian crease in Down syndrome and Shackle syndrome and clinodactyly. So this is the carrying angle. It is shown how it is measured. It is also showing that the normal in the male is 5 to 10 degrees, whereas in the female is 10 to 15 degrees. The excessive cubitus valgus or wide carrying angle, cubitus varus or small carrying angle, and gun stock deformity. But here we are concerned about the wide carrying angle that is in Turner syndrome and Noonan syndrome. And this is the clinodactyly, which is the small finger that is curved inward. Then tell the patient to make a fist. In this you have to see the short fourth metacarpal bone, which can be seen in the Turner syndrome, pseudo-hypoparathyroidism, fetal alcohol syndrome. So this is the you can appreciate that the fourth metacarpal bone is visibly short. After that, you tell the patient to touch our thumbs on the shoulder. This will tell us about the proximal limb shortening in achondroplasia, which is asymmetrical short stature. This is the pictorial representation of the achondroplasia. Then from the side you have to check for the micrognathia, how far the limbs reach on the side of the thigh. If the limbs are short, fingers reach proximal thigh. If the limbs are long, the fingers may reach the knee. Then you look from the back to see the low posterior hairline, kyphoscoliosis, wastic buttocks in celiac disease. Tell the patient to touch toes to see scoliosis, which is present in Noonan and Prader-Willi syndrome. This is a picture of kyphosis and scoliosis. Then you tell the patient to sit up for the proximal wasting and check the gait for subcapsular femoral epiphysitis. Then you check the hands for the clinodactyly, which occurs in the Russell-Silver syndrome, short forward metacarpal bone, which has been told before, polydactyly in Bardet pedal syndrome. Then you check the fingertips for blood sugar marking, nails for clubbing, cystic fibrosis and chronic liver disease, chylonychia, leukodystenia, which occurs in chronic liver disease, brown lines which occur in the chronic kidney disease. Then you check the palms for the erythema, which is a feature of chronic liver disease, pallor, hyperpigmentation, which occurs in congenital adrenal hyperplasia and Addison's disease. Then you check the pulse for bradycardia, which occurs in hypothyroid, radiofemoral delay, which occurs in the coarctation of aorta. Arms, check the bulk, offer blood pressure at the end, check the BCG scar and axilla. Then check the hairs for dry hair, which is a sign of hypothyroidism. Eyes, hypertelorism, which is a sign of Noonan syndrome. Epicanthal folds, which occur in Turner syndrome, Down syndrome, and Noonan syndrome. So how to check the whether the child have hypertelorism? So you have to measure the inner epicanthal distance from both eyes. The normal range is from 1.5 to 2.5 centimeter. Some people can measure the interpupillar distance or the external canthal distance. Then check the pallor, jaundice, ptosis, squint. Then come to the nose, check the nose, mouth for the cleft lip, cleft palate, teeth crowding, and tongue. Then check the ears, then neck for the lymph nodes and goiter. Then check the chest, palpate, apex beat, signs of rickets, heart and breath sounds. Then in the abdomen, see any surgery scars which can be due to IBD, mass due to gonadoblastoma, liver CCF, spleen infective endocarditis, and tenor staging. But ask the examiner before doing this. And check the legs for developmental dysplasia of the hip joint, gait, as already mentioned. Then finish your examination by saying that I want to check blood pressure, do fundoscopy, and plot height, weight, and FOC on centile charts. So I have made a hypothetical description like you can make your own. So my description was I have just examined 8-year-old Pariniti who was conscious and cooperative during my examination. She is well looking, adequately nourished girl without respiratory distress or cyanosis at rest. There is no jaundice and pallor. She is having dysmorphic facies such as webbed neck, widely spaced nipples, shield shaped chest, and low posterior hairline, which are consistent with Turner syndrome. Her height is 100 cm, upper segment is 50 cm, upper segment to lower segment ratio is 1, arm span is 100 cm, weight is 30 kg, FOC is 56 cm, which seems smaller than her age, but I would like to plot them on centile charts. You can say this sentence at the end of description also. Her pulse is 76 per minute, there is no radioradial or radiofemoral delay. Respiratory rate is 20 per minute and is afebrile to touch. There is no asymmetry, there is wide carrying angle, no simian crease and no short fourth metacarpal bone. Thumbs reach shoulder, arms hang till mid-thigh, and no scoliosis and proximal muscle wasting or weakness. There is no clubbing, chylonychia, leukodystenia, BCG scar is present, nails are normal, nose, ear and mouth are also normal. There is no goiter, breath sounds are bilaterally vesicular, and heart sounds are normal in all areas of auscultation with no murmur. The abdomen is soft and no visceromegaly. The lower limbs are normal and the gait is normal. I want to check blood pressure, do fundoscopy, and plot height, weight, and FOC on the centile charts. The investigations are the karyotyping, which can be 445XO in Turner syndrome. 80% of the cases X is of maternal origin. Echo will tell us about the coarctation of aorta, aortic stenosis, mitral valve prolapse. APV or webbed neck patient have increased incidence of coarctation of aorta. 11% mosaic monosomy have less chances of cardiovascular system disease than 45XO. Antithyroid peroxidase antibody is present in 30 to 50% of the patients. If they are positive, you should check the thyroid function test. They can have autoimmune thyroiditis. Then check the anti-TTG for celiac disease. Do the ultrasound abdomen for renal defects, which occur in one-fourth of the patients, such as horseshoe kidney, double collecting system, PUG obstruction, absent kidneys, streak ovaries, blood glucose fasting for insulin-dependent diabetes mellitus, and increase FSH and LH, decrease estrogen and estradiol. The treatment of growth hormone deficiency is growth hormone replacement, which occurs at 10.9 years. The dose is 0.27 to 0.36 mg per kg per week. It should be stopped when the mean height is reached. Oxandrolone with or without growth hormone can also be given for short stature. Estrogen replacement is at 12 to 13 years in girls. Conjugated estrogen 0.15 to zero point 0.6 or micronized estradiol 0.5 milligram for 3 to 6 months. Then cycled for day 1 to 23. Progestin is given for day 10 to day 23. Then withdrawal bleed in the rest of the days. In Turner syndrome, in absence of one X chromosome, there is accelerated process of disappearance of oocytes and all are lost by 2 years. So the 7 million oocytes in fetus, which reduced to 2 million at birth, and there are 400 to 500,000 at menarche and 10,000 at menopause. The complications of Turner syndrome have bilateral otitis media in 75% of cases. They have sensorineural deafness, they can have inflammatory bowel disease, keratoconus, attention deficit, hyperactivity disorder, dyslexia, learning and language problems. Now I'd like to tell you about the flow chart of how to diagnose the short stature after performing the history and physical examination. You have to see that if the patient is greater than 2 standard deviation below the mean or less than 5 percentile moderate short stature, following own growth curve or has family history of short stature or pubertal delay. If there's yes, then you have to check bone age. If there's a bone age, there's a family history of short stature, normal pubertal development, bone age is equal to chronological age. However, if the family history of pubertal delay, and the bone age is less than chronological age, so bone age will be equal to height age. But if there's no family history, then you just check the bone age, complete blood count, chemistry profile, ESR, celiac panel, T4 TSH, insulin like growth factor 1, insulin growth factor binding protein, and karyotyping. Then you check height, weight, and height ratio. So if the weight for age is less than height for age, you consider additional testing for HIV, prealbumin, sweat chloride, celiac panel, stool for blood, and calprotectin. If the weight for age is greater than height for age or weight proportional for height, and there are dysmorphic features present and disproportionate limb shortening are present, then you do the karyotyping, skeletal survey for skeletal dysplasia, radiological survey, consider genetic evaluation. If it is not, then you check free T or TSH, IGF-1, IGF binding protein 3, late night salivary glands. So, if there is a familial short stature, bone age will equal to chronological age. If the constitutional growth age, bone age will be less than chronological age. However, bone age will be equal to height age. So, weight for age will be less than height for age. Then you check the malnutrition, anorexia, malabsorption such as diabetes, mellitus, celiac disease, chronic illnesses. If the weight for age is more than age and there is a syndromic causes such as mixed gonadal dysgenesis, Prader-Willi, Lawrence-Moon, Beadle, Turner, Noonan, trisomies, Russell-Silver. And if there are no dysmorphic features present, then you check the endocrine causes such as hypothyroid, growth hormone, Cushing syndrome, precocious puberty. So thank you very much. Today's video was a little bit longer, but it is very important and a very difficult short case. So best wishes for you. I pray that may Allah be our helper, protector and guide. Allah Hafiz.